Hi, everybody. I'm here with my good buddies Nick and Szczepan as we're gathering for our regular conversation about technology and impact in drug development and more broadly in biomedical research. So we've been trading notes as we often do, agreeing on some things, challenging each other on other things, which is essentially what we do and enjoy doing. Most recently, we've been sort of talking a lot about numbers and data and trying to think through the continuum of drug development and how data contributes to a lot of the decisions that we're making along those ways. And, in me coming from a safety assessment perspective, I'm particularly interested in the numbers that seem to ultimately converge as we go through the process that eventually leads to problems of having enough of a difference between where we get benefit and where we see safety liabilities that you can ultimately have a marketable drug. But as we sort of compared notes on things like AI and different technologies and how that ultimately contributes to those numbers and how those numbers contribute to decisions, we've had some pretty interesting kinds of conversations. And so we thought we'd kind of tee that up and compare notes and see where the conversation went. So, guys, thoughts about that?
Yeah, and so when you said, you're going to do drug development as a math problem, and I thought that was pretty interesting, and I didn't realize that's how you thought about such things or even cared enough about math to phrase it as such. But then, immediately I kind of thought about, well, what about drug, discovery and development as a data problem, right? Because it's math is usually, an individual number, a point estimate. Can you bring a broader kind of data with a given distribution? And, I had two thoughts off the bat, and then I'll gladly pass it back or pass it to Szczepan. But one, was, well, first off, if we want to, how do we know if we have the right data? Are we using the data that's sitting there for the right purposes? Like, why would, with it for an appropriate use given the context of why it was generated. And then you have to back up further and say, like, okay, well, if we're trying to figure out, do we have the right data to de-risk drug development or drug failures, let's revisit why we have such an abysmal failure rate as we do anyway. So let me pause there. But of course, the number I like to throw out there, and every year I check, is at 90% kind of failure rate of what at least is ready to go in human. And you can do the accounting different ways, but I mean, no matter which way you do it, I don't think it's qualitatively, it's not going to change, right? And we all realize this. So and it's the other way is like, we called it a math problem, a data problem. I also like that drug development is also a risk mitigation exercise, right?
Yeah, and it's so I'm aligned with everything you guys are saying, and I think sometimes because we do things so rapidly and so fast, the pressure is to move faster and faster and faster. Sometimes even when we design studies, we don't really think what we kind of know what's the main data we should be collecting, but what's the metadata, right? That we should keep adding with it. And I think one of the things what we're learning recently, and there's multiple initiatives here in States and in Europe, and I'm sure all over the globe, that we have digitized our data that we already have, and we think that data is already AI ready, or even looking back and doing analyses, like the whole thing idea we're talking about the culture of learning. But what we really are finding, right, that the data is missing a lot of different things. We didn't collect some things as well. When you cut and paste it, right, errors come up. So I think moving forward, we really need to focus on what that truly means, and what that should look like. I mean, one of the things that I really learned, at Novartis, when I was at Novartis, right, high quality data, we all talked about it, especially as the decade of clinical data was being digitized, but it really, I underestimated what that truly means until I joined Verisim. And there, a lot of times when we receive the data from clients, it's supposed to be AI ready, right? And we very politely had to come back and say, no, it's not, right? We have to curate it and reassess it again. Yeah, I think that aspect that we all talk about, garbage in, garbage out, everybody says that. We say we need high quality data. But in reality, we're not necessarily, even for current studies that we're designing because of that speed, we're not necessarily collecting or identifying what the data should be.
Yeah. No, related to that, we've all worked for companies that have recognized that there's a lot of value to be derived from the data we've been generating for decades. And to the point you just made, Szczepan, unfortunately, that data is not always in a good format or curated effectively or have the right metadata to contextualize it to get the full breadth of that value from it. The other side to that is actually recognizing whether it's the right data to begin with. One of the things that I commonly whine about that ultimately you guys are victimized by is the fact that I feel like that we're trying to use data to drive decisions and predictions that wasn't actually generated to inform those decisions or make those predictions. And so I think that not only should we continue to try to leverage our past experiences, I think we need to think critically about how we generate the right kind of data for the kinds of things that we're trying to do in the future. Safety assessment is a perfect example of that, where our usual approach has been one based very much on sort of phenotypic apical outcomes. That's the way we like to talk about it in a pathology, pathogenesis perspective. But yet we want to make more predictions. Well, you need much more mechanistic kinds of insights into that data to be able to predict where it's going to go. But some part of that is limited by our fundamental lack of understanding about pathogenesis and how bioactivities evolve from an adaptive to a maladaptive state and all those kinds of things that again I whine about and think about a fair bit. So I'm saying that to say that it's not just about taking the data we've already generated and try to make it better by putting more structure around it and credibility and all those kinds of things, but actually thinking about a different kind of data based on what we're trying to do in the future that's different than we did in the past.
Yeah, and so I fully agree with you, Brian. Right, and so as a good example, and again, thinking about predictions, right? So we end up using physical properties, right, of different compounds, right, to kind of predict what's going to happen, right? Because from previous data that we have and etc. But and we have done that, right? We do that extremely well. But even if you add like quantum mechanics to that, right, the energy of atoms and etc., that's way beyond my area of expertise, right? But we published a paper, I think a year ago or a couple of years ago. When you combine those two together, your prediction increases, right, or get the accuracy improves. And again, so like you said, right, it's bringing the right data together, but also understanding what questions you're asking, what questions you are going to ask of the data, and combining it. And again, very often, like I mentioned, I'll keep going back to that, right, is because we're so pressed for speed. Sometimes, we kind of push things aside because we just don't have the bandwidth to do it. And that ends us, we move faster, but we keep ending up, our translation, it's not really increasing. So again, the whole aspect, and we talked about it a while back, right, just do, failing fast, right, what everybody's pushing for. But we're doing that, right? We're doing it faster, right? But the failure rate is still the same, and we're not addressing that.
So I'll jump into, why do we have such a low approval rate or such a high failure rate? So I liked, I'm coming more from the world of, earlier stage. And so, you mentioned, quantum mechanics or maybe, treating quantum chemistry and quantum descriptors. I mean, that will definitely help with certain early stage modeling, right? And affinity is super important, but I feel like at least, from affinity, and Brian will hit this point later too, PK, PD, like there's a lot of data and we can at least observe how well we are or are not doing from an earlier stage, understand the trade-offs and start going under the, start doing multi-objective optimization. A lot of these failure rates, at least what would keep me up, and especially where you're looking at investing early stage in companies, translatability seems to be such a huge risk, and that has nothing to do with better treating of midlife. I don't think we're a long ways from quantum descriptors helping us with translatability, I think. And so it's I was looking at and there's different theory, and we're moving in that direction, but how to better predict at an earlier stage exposure to a given tissue, like how to understand if the target is is going to translate from whatever assays you identified it on, to a human population. Is it going to actually get all the way to engage your target? And then, even if your target might translate in certain ways, is that even going to translate into a clinical outcome, not just an immediate kind of molecular readout? Depending on what that endpoint is. And so I think there's a lot to think about there, but now, and then maybe there's one nice anecdote you could use, like, well, if translatability is a big risk, rather than going strictly from kind of a cell line for doing your target ID, can we start actually having, EHRs, patient data, disease repositories being part of how we're defining populations and identifying, using maybe ML over kind of real world patient populations, maybe plus some other things as well, in the early stages of understanding the disease pathology that's going on there. Because if you do it that way, then you're more likely to be guaranteed that, what you're doing is going to translate to humans, because you started with at least some input from real life humans, right? And so, and so you'll see some startups that have, that's part of their kind of a, USP is that, like, the way we're doing, say target ID in a machine learnable way, then you can use these features for defining your actual, not only is it more likely to be translatable, but you can use that in your trial design later on, right? So it's just one anecdote, but I think we could have the same conversation for, maybe I'll ask you guys then in the realm of preclinical safety. And you guys have been, one of the common themes the two of you revert back to is animal models, and will modern technology like organoids, microphysiological systems, will these help us get rid of our dependence on animal models who might not translate? And then, like, well, yes and no, because there's part of the problem might be that it's not in a complex, full animal system, and the part of the risk is that, well, that live animal system isn't human, right? So maybe that's a good time to pass the ball back to you guys, because when I was looking at, and let's just put in perspective the reasons these things fail, 50% efficacy, that can include certain types of animal models, right? But then 20 to 30% is safety toxicity. One of the things we can talk about is, like, those two are actually linked through dosing, right? But then then we can come back to, there's still another 20-30% that is strategic, commercial, and operational and design issues that have nothing to do with again, quantum quantum descriptors, right? As much as I love them. So let me pass back to you guys with a little bit of that thought on translatability and technologies and
Just following that thread, Nick, I think that's some great points. I, as a comparative pathologist, I have a very, very, very strong belief in the conservation of biology and pathobiology across species. I think where the train comes off the tracks is in that quantitative translation. I think that some of these newer modeling strategies that we think are more human relevant are going to be just another way to fail, unless we can get a better handle on understanding the quantitative extrapolation from preclinical to clinical. I believe that the things that we describe in animals are happening in people. They're probably just happening quantitatively in different ways. The other part of that is ultimately thinking more about that human context, as we were talking about earlier. Because of the way we practice medicine and apply healthcare, we're engaging disease processes way down the pike. And so I think personally, as an industry, we've gotten really good at designing molecules that will engage a target, modulate that target, get pharmacology. Efficacy is the problem, as you just noted. And that's because you've got a disease state that's so far down that you can't quantitatively change that target enough to change the course of that disease. So there's two parts to that equation. One is you got to get targets that have more relevance to the stage of the disease that you're engaging. And we probably need to start identifying patients that are earlier in the stage of the disease, so you have a fair chance of actually being able to modify that. So even though it's du jour to pick on drug developers and their lousy success rates, it's not entirely their fault. And so I guess I'm being defensive because I've spent a lot of decades, sort of contributing to that. And to some degree, that's pushing a rock uphill because of the way that we practice medicine. Now, that's not to go off on a tangent here, but that's why I'm excited about the emergence of digital monitoring capabilities, the opportunity to actually start engaging a disease process earlier in that process because it's starting to happen, because you've seen a divergence from a usual normal baseline in an individual patient. I think it's potentially going to be where the math starts to become less of a problem because we've got a better engagement on the clinical side and a more effective modulation on the preclinical side.
And so from that, Brian, right, is that the preventive healthcare, right? That's what kind of starts making me think about, because again, then we're able to actually monitor, like you said, with the digital biomarkers or endpoints, whatever you want to call them. And so as you guys know, right, routinely, right, I typically wear 5 or 6 wearables, including like a blood glucose measurement, right? And that actually does help me, right? Because I monitor the blood glucose, right? So if I see it, right, changing, right, I end up adjusting my habits pretty rapidly, right? But at some point, right, that will not be enough, right? Because if I have some kind of disease state, but then again, I'm able, I get the baseline, right, what it is for me, not what it is general from the public for, different groups of people or, sometimes even patients, right? So catching those things sooner, right, and starting even, started different medicines earlier, right, because I was able to catch that, like my blood pressure. But sometimes if we don't do that continuous monitoring, right, then we're catching it, like you said, at this late stage. So then the chances of us addressing that disease are lower. And I think also what you mentioned, one of your, in a previous newsletter, right, talking about that we look in the studies for an effect, right? But your suggestion is, which is a pretty basic question, right? We should actually look at, at what dose, at what time we actually have that kind of effect, right? Or we don't. And again, it's a simple, both things are kind of asking the same thing, but you get more detail. And that's where going back to the data, when you ask those more detailed questions, right, or more granular questions, now it also tells you what data you should be collecting. In addition to maybe this one biomarker or 2 or 3 biomarkers that you thought initially. So I think all of that just would help us actually then to increase the productivity of our preclinical and even in a clinic as well.
So that's a perfect example of thinking about a different kind of data, right? So thinking about biology and pathobiology more dynamically is very different than the kind of data that we're generating right this minute. And up to and including actually even in the clinical setting.
So I was going to say there's a kind of a common theme to what you guys are talking about, and it's are we trying to, are we doing our biomedical discovery in a way that aligns with the ability to kind of perturb and have an impact on a disease, right? And one of those could be in the models themselves. Like you keep the same sort of mindset, and then eventually you hit. And Brian, I was going to ask you. You mentioned efficacy and safety, and then you've mentioned you think there are many robust safety signals among animals, but there's also the step before preclinical safety. You're looking at the efficacy in actual animal disease models as kind of a step towards informing humans. And is that one is is that a large? So a couple of questions. One, is that a larger step from the safety findings because you have to try to recreate diseases that might not be replicable in all species? The second was, even if we're doing it in this way, Stefan mentioned is fail fast. So are we, if your molecule isn't specific enough, or if it, lacks affinity, there's ways you can, go to a bifunctional antibody. You can use a different chemical series. You could even back up and use like a target up or downstream, versus when you've made a fundamental error on understanding the disease biology, that's just, no, you have to kill the whole program at this point. Or you could get unlucky and like the entire pathway is just like not safe to be treating, except we're in an age where you have more and more ways to deliver that, in a very targeted manner, right? So like, okay, what critical mistakes could lead to making me having to kill the program rather than just to kind of evolve and kind of iterate a little bit. And then it led to that last point, which, Szczepan, there's this mindset which we could get into in a future call of, rather than finding, that target that can help you with a advanced disease state, we can try to keep people healthier longer, or even start to restore the body's natural ability to kind of rejuvenate, heal, and regulate itself, which, I'm involved with a couple of startups taking more of this mentality, right? And for doing that, you can start looking earlier at actual people and, molecular outputs and these types of things. So I guess it's kind of a couple thoughts wrapped into one, and like, well, how are we thinking about how to identify, on a molecular level, disease and health in the right way? Does there need to be a strategic mindset in pharma? If we don't do that, are we in danger of having to kill entire programs rather than, being able to pivot with all the tools we have available today? And, is efficacy versus safety more vulnerable to this style of non-translatability? So it's a heavy question, but I'll pass it to you guys if you have thoughts.
No, I'll follow a couple of those threads, Nick, and I'll admit that I think we spend too much time doing running animal disease models.
Yeah.
That are misinforming us, and we do that because it makes us feel better that we think it's going to translate, and too many times it just doesn't. I think that those animal disease models are great ways to get insights into a disease process and come up with novel targets and those kinds of things. But I don't think they're a very good validation for the likelihood that it's ultimately going to affect a human disease. We need to spend more time studying human diseases in humans. And I think we have a whole lot more capability for doing that in non-invasive ways than we did 50 years ago. And we're just not taking as much advantage of it. I think that we ought to be doing a more robust job in understanding sort of pharmacological bioactivity, how that relates to the potential for toxicological bioactivity and the balance between those two. And then ultimately getting into patients where the real disease state and the real variability that is represented in the human context is better represented. And so that's a long-winded way of saying that one easy way to start saving animal use or reducing our dependence on animals is stop doing studies that are just not helping us anyway.
Yeah.
And using them in a more appropriate way. Yeah. As an example of that, one of the things that used to drive me crazy, amongst lots of things used to drive me crazy, so I'm probably crazy, but is when in a pharmacology efficacy study in a cardiovascular area that we would do echocardiography on rats. Physiologically, rat hearts are very, very different than a human heart. And so we did the echo because, well, that's something they would do in humans. And so it gives us this false sense of security that if I saw something change, then something's going to change in people. And it's completely irrelevant because of the difference in the physiology. So that we were doing that as an artificial bridge of confidence, not because it meant anything from a biology perspective.
I like that. For hypothesis gen can be great for getting ideas, but for trying to quantitatively assess how well you're doing or do the translatability, less so, right? And there's an increased amount. So step one is not completely overhauling how you do drug discovery, but at least looking for these genomic signals within a population, Mendelian randomization, or these types of things to say, like, okay, is this a correlative or causal actual target? And then you can go back and try to look at the disease registries and these types of things. And my only other thought was Szczepan had said something in the beginning about the context of the data you're trying to use in all of this. And I think better leveraging the knowledge, expertise, and past data within an organization is going to be key. And I think in what we're writing next month, I'm looking at these neurosymbolic architectures to kind of better structure knowledge, but using modern tools to help actually get more use out of it, and even to help you keep it structured and up to date. So those are a couple of things. But and the other one, Szczepan, like you said, I mean, identifying patients earlier, but just and just having more and more people participating in kind of digital health, owning their health, generating real world data sets, especially that contain functional tracking of people. You mentioned wearables and things. That's, I think, an incredibly exciting area to hop into, and maybe the more short-term value we can provide people to participate and optimize and help optimize change their own behavior and health, the more actual insights we'll have onto where disease progression meets lifestyle, meets genetics, meets some other types of it translates into even soluble biomarkers we can start detecting, and gives insights both into how to stay healthier, how to monitor how healthy you are, and also a little bit of stocking of the next drug discovery pipeline. So I think that'd be a fascinating thing to get into in the future as well.
I mean, one of the challenges also with these technologies, right, is that, how to use them and educating people, right, that are not in our industry. So like initially when I started wearing these, 6 wearables, right, it took me about 2.5 hours each day, right, to make sense of the data. Because one of the challenges that even though like one wearable measures maybe 2, sometimes even just one thing, right? But then when you look on the platform, it extracts all this different information that indirectly, right, that you can calculate it. And then so then it becomes overwhelming, right? All this information that you get, and what does that really mean? And again, this company's doing an amazing job at that, right? And every so often they add another thing, right? But we have to understand or remember, right, that all of this information is being calculated indirectly, right, from one measurement or 2 measurements. And then when you combine the different wearables, right, because they do different things, how do you end up interpreting the data? Because it can be really overwhelming. I mean, to be honest, after a couple of months, I stopped looking at the data because I was getting all anxious, like I'm not sleeping enough, like I'm not, my food intake isn't inappropriate and all those things. And I have colleagues and friends that actually stopped using those technologies, right, because they constantly get an alert and et cetera and all of that, right? So I think if we also need to educate how this technology should be utilized to help, and collect the right data. Again, that's where identifying the right question. And some of it also goes back, Nick, we talked about the context, right? So I still find it, kind of really frustrating and amazing in a way that a lot of, so like for iStent, right? So it's a program at FDA that, for folks that don't know this, they're listening to us, right? It's a program where you can submit novel technologies, right? And FDA goes through the process of qualifying the technology or a platform, right? And then so when I work with some of the companies that end up developing the context of use for it, it's amazing how much off it is. And even in large pharmas, when initially the context of use is being written down, it's totally off base. Right. And the main idea there is, right, the context of use, the decision should allow to make the regulator, are we going to move forward or not? Or maybe give them more confidence in their decision. Right. So it seems pretty basic, right? How would you define it? But again, to your earlier points, Brian and Nick, is that, understanding what you're actually looking for, what question are you answering, and what data you're going to be collecting, right, helps you do that. And so I think, again, this is where, giving it more time, not rushing through it, and will help us refine that and then collect the right data, preclinically, clinically, but then also in people, before we get sick.
Szczepan, you brought up a couple of interesting things, and I'm only going to pick on one of them because we're going to run into a length of time here. And that is, and it was novel, that's why I want to say something about it. That is the danger of data. again, having worked in regulated settings as we have, we recognize that we have an aversion to generating data that we're not entirely sure what it's going to tell us, because it potentially could be a liability, right? And the same thing is true when it comes to an inability to understand what to do with that data. An example, we in the days of my early days in cardiovascular safety, when we were talking a lot about troponin as a biomarker and the ability to use troponin even as a translational biomarker in patients, where it traditionally has been used to help diagnose a patient who's having a heart attack, right? The idea of monitoring troponin as a biomarker of much more subtle myocardial injury was a concern to clinicians, because the current state of medical care was, if I had an elevation of troponin, I would take the patient to the cath lab, and there's risks associated with that. So that data was potentially would instigate an action in a patient that would put them at more risk than the data was reporting. And so you have to think through the entire sort of life cycle of the data, and even the risks that come from generating that data if you don't know how to interpret or apply it. And so I think that's another really important part of the overall equation around data.
Maybe one follow-up on that. I was trying to find some notes from actually early this week, and I don't know if I quite found them in time. But I liked both of your points, and Szczepan had mentioned that you can get all of this data, and it doesn't have to be just wearables. It could be like certain new types of molecular omic style screening technologies for metabolic or oncology disorders. And but some of the feedback so far is they can create a lot of false positives, and sometimes the patients, or not even their GP necessarily knows what to do with some of them, and sometimes there's nothing actionable anyway other than just freaking you out the rest of your life that you might be at risk for something, right? And so I have talked to a couple of startups recently, one in particular who was trying to orchestrate and provide this ability to integrate some different types with practical things, next steps towards care for you and GP, right? And I think it is critically needed. And that conversation led to, I don't know if it's endometriosis or some kind of FinTech style project, but there have been kind of sometimes critical gaps where under focused on undertreated kind of areas where people are actually trying to help use digital AI to create that layer, right? To help you understand, it's almost like a concierge style layer for certain indications. And you can think, especially let's say in oncology, where there's so many different forms, and there's an increasing amount of multi-cancer early detection style platforms out there. It could be imaging, it could be DNA, it could be omics, right? And so how is the confusing, and I don't even know what to do. Like, I'm a middle-aged, and I'm not sure what I'm supposed to do, and how is like anybody who's not coming from the biomedical world, as you said, Szczepan, supposed to know exactly what to do, and how to feel comfortable doing it, and not too scared to even wade into it, right? So I think these are solid points, and one of the future points for us also could be, if you think of medicine more broadly as tools, be it molecular, digital, anything else you want, or simple knowledge, to have a positive impact on our own and populational health. How can we start thinking a bit more broadly from beyond just molecules, but also what is going to be the continuing role of molecules, and where do these types of things meet? I think that would be something to jump into in the future as well, right?
Yeah, no, thanks, Nick. And because we're running against the time, I think my last comment here is that when you said middle age, I keep saying the older I get, I still keep using that term, right? I'm middle age. And recently my kid said, it's like, Dad, when is that middle age going to end for you? Because we think you're past that middle age. Yeah, I guess talking about terminology, but
that's a sliding scale.
Yeah, that's why we're trying to come up with tools to help us extend our health span, not just our lifespan, right? And this is the goal keeps moving, so that's why we continue to be middle-aged.
Yeah, no, definitely. All right, so with that, we're gonna end. I hope you guys enjoyed what we had to chat about. At least we did. I guess maybe that's, I shouldn't say maybe most important, but anyway. So I hope you guys join us next time on us going back and forth a little bit. And so with that, we're gonna jump off. Thanks, everybody.
Thanks, guys.